Welcome, everyone. For those who are not on our opening session, my name is Erin Foley, and I am your moderator today. For this session, I am very pleased to introduce Dr. Joshua Stilley. Dr. Stilley is a doctor of emergency medicine and also chairs the Missouri State Advisory Council on EMS. He's going to be speaking with us today about adrenal crisis and EMS. What are the standards and what are the expectations? Dr. Stilley was unable to be with us today live, so this is recorded. If you have a question for Dr. Stilley, you can still enter it in the Q&A and we will be sending them to him in follow-up. That said, you'll want to enter your question before exactly 11:30 when we end, because then the Q&A will close. And with that, we will play Dr. Stilley's video.
Hi, I'm Dr. Joshua Stilley. Thank you for having me today to talk. This is a presentation on adrenal crisis and EMS. So I'm an emergency medicine and EMS physician at the University of Missouri. I've been working with the National Adrenal Diseases Foundation for the last several months, specifically in relation to how can we better partner between our advocacy groups, our providers, and our patients with adrenal insufficiency, and our EMS and emergency medicine clinicians for better and improved care for our patients. So this presentation is going to cover a little bit of background about EMS, what it is, how we function, what happens, some of the great things about EMS, but also some of the limitations, and how we can partner together for good care going forward. So I appreciate your time. So a couple of different things: identify the capabilities, understand some challenges, and again, improve communication. Why are we having the talk? So adrenal insufficiency is a true emergency. It's not a big one that's recognized a lot in EMS. When we look at what types of patients do we see frequently or commonly, adrenal insufficiency is not going to be a large percentage. In EMS, we spend time focusing on where do we get a lot of patient contacts and making sure we do those well as all of the other areas of medical care that we experience. So there is time and attention put towards treatment of critical patients, but we have a lot of other things that we treat as well. But EMS is the first medical contact. We see you before you go to the hospital if you call 911. So it is important that we do well and get it right. So we want you to understand what EMS can and can't do and how you can advocate for yourself and how we can partner together. I think a good question to start with is what happens when you call 911? Seems like an easy thing, but there's actually a lot going on behind the scenes. So you make a phone call to 911, it goes to what's called a PSAP, a public safety answering point. That is just who takes the phone call. Sometimes that PSAP, the dispatch center, will keep you on the line, get your information, and send an ambulance. Sometimes it goes to a medical call taking center. So instead of you staying on the line with the first dispatch center, it may in fact go to another one. As an EMS medical director, I have services where all of our dispatch happens in one location and services where we do send patients to our medical dispatch center. Very much just depends on the system. So you call 911, somebody picks up, and then you talk with a communicator. So they're going to take your information. Most of the time, the information that they want first is your address and your phone number. And then they're going to ask what's going on. So as they ask questions, just be calm and work through. There's also a good chance they're going to use what's called EMD, Emergency Medical Dispatch. This is when we take information from you, medical type questions, and put it into a protocol that helps us decide what resources to send. We don't want to send too many resources, but we do want to send enough resources. So it is important that we have the right capability for you. So they're going to take questions, put those into the computer, and then the responders usually will be able to see in some sort of system what you answered. Not always. Sometimes they don't see it. Sometimes it has to be communicated verbally from the communicator to our EMS clinician, but sometimes they'll read it through a program. We have different ones in a response vehicle like I'm running today. I have an iPad that I can pull up the notes that our call takers have. If I'm not in one of our response vehicles, I have a phone app that has some capability for that, or I can look it up on the dispatch center depending on where I'm at. So they take information to try to get the right services out the door. So be patient. If they're asking questions, it's for a reason. Answer the questions as you can. And then that message goes out by radio. It's supposed to be a radio on the icon. Goes out by radio and dispatches a unit. So different types of radio systems are in use, but that information is sent out, gets a unit en route. Ideally, what happens as soon as the call taker gets enough information, they are sending the right resources, even while they're still on the line answering questions. We call that parallel processing. And most of our dispatch centers are able to do that. So while they're taking the questions, may seem like a lot of questions, but they're already going to have the first set of responders en route. That may be an ambulance on its own. It may be an ambulance with first responders. A lot of areas have a fire department or a medical first response unit that will go out in addition to the ambulance. We do this for a couple of reasons. Sometimes the closest unit to a patient is a first responder with the ambulance coming from quite a ways away. That happens in a lot of rural areas and actually happens in a lot of urban areas as well. So we want to get help to a sick patient as quickly as we can. Sometimes they are sent just because they are additional resources. A lot of cities, if you have a separate ambulance service from the fire department will go on the vast majority of calls, even if it's not as critical, just to be extra resources on scene in case equipment is needed to move, there needs to be help lifting or moving the patient, or we need assistance with transport to the hospital. So lots of things can happen in that background, even before anybody arrives, just to prepare to treat you well. When we show up, there's going to be a few different types of clinicians present. And I think this is one of the areas where there can be a lot of unknown with the responder. You know, in many areas of the country, we're blessed with ALS level care. ALS stands for Advanced Life Saving. So that would be an advanced EMT or a paramedic. However, in a lot of areas still rely on BLS, basic life support. So those would be an EMR and an EMT. Sometimes they are in a tiered system, depending on how the questions are answered. You get a BLS ambulance or an ALS ambulance. Sometimes that's just the capability we have available. EMS, like a lot of other areas of employment, we need more people. Every agency that I'm the medical director for, we have a need for additional people at the EMS, or excuse me, at the EMT and paramedic level. It is a job that some people stay in it for a career, but some people start and move on. I myself started in EMS a long time ago as an EMT firefighter, and then went on to medical school. So we are fortunate to have people continue to move up the healthcare ladder into nursing, PA and MP programs, and into medical programs, as well as administration or other jobs. So that turnover, though, is problematic because we still need people to run calls. So we're constantly trying to find more people. So sometimes it's a staffing, sometimes it's just other limitations where an EMT ambulance is what is available. And we'll talk about why that matters here. So it's called scope of practice. Depending on certification, licensure, and then local credentialing. So certification is proof of education and competency based on their education program. Biggest one in the US for EMS is called the National Registry of EMTs. They have a large database of questions. Folks, when they graduate the EMT or paramedic program, will take one of two credentialing or one of two exams at the end of their education program and get certified as an EMT or paramedic. Then that goes to the state where they get licensed. That allows them to practice. Just like a license allows you to drive a car, an EMT or paramedic license allows our clinicians to actually provide care. And then credentialing, that's the process of the local agency saying that you are allowed to provide this care that you are licensed to do. So it takes all of those in order for somebody to actually give care in the field. The protocol are what actually directs the care. So a protocol is a requirement because to give care, you actually have to have a physician order. In the hospital, those physician orders usually go into the computer in real time for that patient. Sometimes we have protocolized orders. A prescription would be a similar form of a physician order. Physician has to write that order for care to occur. In the field, we need the same thing. So an EMT and a paramedic cannot just go out and do whatever they want. They actually have to have that written physician order. And we do that by protocol. So I develop protocols. I write them, I look at best evidence, and then I publish those, and we provide education and training on the protocols. Those protocols can be highly variable. I'm in the state of Missouri. In Missouri, I, as the medical director, write the protocols. I am responsible for the provision of care. In states like Iowa, which I know well, that's where I did my training, there is a state standard protocol set, but then the medical director is allowed to go above that. So some folks use the state standard set, some folks go above and beyond that protocol set. And then there are other states where there is a specific protocol statewide. So everybody in the whole state does the same protocol. There is good and bad components of each of those systems, but for you as the patient, it means that whatever is the protocol, that is what the clinician is allowed to do. Then what we can have is an online medical control order or online physician order. There's always a physician at a hospital that an EMT or paramedic can call and ask for help. We do this quite routinely, not every patient, but not infrequently. If you ever have seen the old show Emergency, back from the 70s when EMS first started, every time they treated a patient, they called back and got a physician order. Fortunately, we don't have to do that anymore. That would take a lot of time. Most of our care is off protocols, but every once in a while, either for complex situations or high-risk scenarios, our clinicians will call back to the hospital. Sometimes that's the hospital, sometimes it's the medical director, sometimes it's other physicians that are directed by the service or the state who take those medical control calls. A lot of interesting systems out there. For us in our system, we call the ER as our primary site, which is fairly common. The paramedic can get help, or the EMT can get help with provision of care, understanding what is going on, what best to do for the patient, and how to care for the patient. And sometimes that's a time where they can ask a question too. And we'll talk about it a little later, but if you as a patient or a family member say, hey, we need treatment for adrenal insufficiency, and the paramedic is not as familiar with that, that presentation condition treatment, they can call in, ask questions, and on the phone get a physician order for treatment. So we talked about it has to be a physician order. Usually that's protocol, but a medical control order or online physician order is an equivalent way to get that order. So it allows us to provide care. However, a medical control order doesn't allow care outside of the scope of practice. So for the EMT, that basic level of care, they can't do an IV, and there's a very limited number of medications that they can administer and routes they can administer it. So even if you have a written physician order, or they call medical control, or you have a home order, an EMT is not likely to be able to give medications that, or in a way that are outside of scope. That is a fairly strict limitation. It would be like you have a driver's license to drive a car, you get in an airplane, you don't have a pilot's license. That's not something you're allowed to do. That is outside of your licensure to operate a vehicle. It's a vehicle, yes, but it is a very different type of vehicle, one that you're not trained or licensed to utilize. Same thing would be for the medical side, for going above and beyond scope of care for an EMT up to the paramedic level. So some of the stories I've heard of concern or conflict in treatment of adrenal insufficiency patients in the field is the patient saying, or family saying, we need the hydrocortisone administered IV or IM, and the clinician saying, I'm not allowed to do that, I can't do that. Without having all of the specifics, the scope of practice limitation is one of the things that I think would be a common barrier that is experienced in that sort of setting. So a medical control physician cannot order an EMT to do something above their scope. So even if you get a physician order, that's not something that they're allowed to do. It actually is a limitation of their licensure and credentialing to do that, and would be an illegal practice. So that is not something that they are going to be able to do above and beyond. But a paramedic, depending on the state, may be able to do that. And we'll talk about that in a little bit. EMS is fun. EMS is a challenge, and EMS is really hard. There's a lot of interesting components that we get to experience with EMS care. So we get to treat a wide variety of conditions. So traumas, strokes, asthma attacks, adult and pediatric patients. I'm the medical director for a pediatric transport team, as well as multiple ground ambulance services. My ground ambulance services, even though I have a pediatric specialty team, they're not an adult ambulance service. They are credentialed and trained to treat adults and children both. So they are an ambulance service. And that can get complex and difficult when we talk about equipment and medication dosing and other intricacies of care. But when the ambulance shows up, no matter what the 911 call is for, they are prepared and equipped to treat that as good as anybody else. But it requires us to be aware of what's going to happen in a car accident, or if we arrive on scene and somebody's having a stroke. There are lots of things that our paramedics and EMTs have to know for the provision of care. Paramedic school takes about a year. EMT school is about a month if you're doing it full time. Those are very rough numbers and there's a lot of variability. But in a year, that is a lot of information to be able to comprehend, learn, understand, and apply within a year of training. Ambulances have limited space. We can't carry everything that we want to carry in an ambulance. There's only so much equipment, medications, and depth of supply that we are able to have on any individual ambulance. We also need to be cost conscious when stocking an ambulance. There are lots of things I would love to have on an ambulance, but don't make a lot of financial sense. And that's going to be different for every ambulance service when they look at their patient population, their call volume, the transport time to the hospital, and their budget. They're going to make decisions on what they're able to stock and carry in an ambulance and what they're not. In EMS, as I was saying, there's some chaos. When we arrive on scene, often there's a lot of unknowns. You as a patient or a family member have a good understanding of what is going on, and the EMS clinician is walking into it without a lot of foreknowledge. No time to cram for the exam. They are there with the knowledge that they have and the equipment they have. Sometimes those dispatch notes can help a lot and help set the stage, but a lot of times we walk in not knowing exactly what's going on. All right, how do we treat adrenal crisis in EMS? Well, I always try to stick to what I call the fundamentals. Good fundamental care, kind of like dribbling a basketball for a basketball player. These are the things that we have to do well to get good success. One of those is a primary survey. So actually getting in, looking at the patient, doing a good exam, looking at airway, breathing, circulation, disability, and then exposure, or ABCDEs. That's a common term that we use in healthcare, the ABCs. And the primary survey is where we want to start. We want to make sure that patients are breathing well, blood is moving with good perfusion on the circulatory exam, and that there's no signs of hypoglycemia or stroke on the disability exam. Next, we're going to get vital signs, and glucose is a really important vital sign in a lot of our patients, especially in adrenal insufficiency, where that can be a common presenting complication. So we'll get a primary survey, we'll get vital signs. A lot of time that's a monitor, just like when you go to the hospital or a clinic. They wheel out the machine and put the blood pressure cuff and the pulse ox on. That's going to happen in the vast majority of EMS agencies, as well as monitor application to get those vital signs. If the patient is sick, we really want to get that IV access done on scene so we can start our resuscitation. Most patients that are stable are going to go out to the ambulance first. One of the conflict points that I see a lot of times between patients, family, and clinicians is that movement to the ambulance, sitting there and then not going right away. Well, I can promise you, in the back of the ambulance, we are doing things to try to make sure that we're ready for the transport phase. Things like starting an IV, doing any more assessments like a 12-lead EKG or any other exam that's needed. Again, if the patient is sick, I really push my clinicians to do that before we move to stabilize on scene. But a lot of times they're going to do that in the ambulance. A little bit easier access to the patient, a little bit easier access to equipment, and that's their work environment. That's their office. That's where my paramedics feel very comfortable. So that is a really common thing to have happen. So if you see that happen, but the ambulance still sitting there, promise you they are actively working, trying to care for your family member. Things that we do very commonly, IV fluid. Oh my, we do a lot of IV fluid in EMS. So that will be a common administration, helps with perfusion, dehydration, and just bringing up the blood pressure a little bit. Dextrose is another common thing that we do for hypoglycemia or altered mental status. Most EMS agencies have switched from D50, the really concentrated dextrose, to D10, which comes in a fluid bag. So it'll look like a bag of fluid, but it is much easier on the veins and equally as effective. So we give a lot of dextrose. I hooked one up this morning already. And then steroids. Steroids, this has been a fun part of the conversations I've had with folks from the NADF. There are three main steroids that we look at in the emergency care setting and with adrenal insufficiency. So Solumedrol, which is methylprednisolone, and dexamethasone, which is Decadron. Those are actually the two most common steroids carried for EMS. And we actually give a fair amount of steroids. Asthma exacerbations, croup, epiglottitis, or COPD exacerbations. It is not uncommon for steroids to be administered. Solumedrol, the methylprednisolone, is probably the most common steroid for EMS, and that's just because it's been the one traditionally used for a long time. So if you see methylprednisolone, that is quite common. Problem for adrenal insufficiency, as I'm sure you're well aware, it's not as effective management, so it doesn't provide the right stimulation that we need for patients in adrenal insufficiency. Dexamethasone does do a little bit better job and is okay for adrenal insufficiency, and is not terribly uncommon in EMS. We use it a lot in the hospitals, starting to make its way into the field with EMS. And then the last one would be the Solucortef, the hydrocortisone, the best drug for adrenal insufficiency, but not commonly carried for EMS. A couple of reasons for that. Traditionally, it hasn't been a medication that has been necessary for emergency medicine and EMS to administer commonly, so it's just not as familiar to us. Second issue, the methylprednisolone, the hydrocortisone is actually significantly more expensive than the methylprednisolone or the dexamethasone. And when we look at cost and utility in EMS, it may make the difference buying a more expensive medication versus a less expensive medication if we're even able to carry the medication at all. In rural areas, especially where I'm a medical director, our budgets are tight, and we really have to balance our operational and equipment budgets very closely to make sure that we can maintain an ambulance service, pay our folks, and turn the lights on and respond when 911 is called. That is a very real concern for a lot of our services. So we take that into consideration. And that's something that you can help work with your local service to decide if they need to be carrying it or not, and work with your local advocacy groups in that determination. So methylprednisolone, we give a lot. Dexamethasone starting to gain traction, and then the hydrocortisone, less common. However, almost all paramedics, even if we don't carry it in our medical supply, is going to be within the scope of practice of a paramedic. There are some variances depending on location, and this is a good thing to know. But on the whole, especially where I'm at in Missouri, a paramedic can administer hydrocortisone. It's within the scope of practice. We would either just need it to be available from the family, and then a physician order, written plan, or online medical control order to be able to give that. So challenges, we've talked about a few. Large variability in patient presentation. And when we show up to a patient, even with known adrenal insufficiency, it may be difficult to determine that's what's going on today, whether that's just not known they have adrenal insufficiency and thinking about it and triggering it, or patients we know have adrenal insufficiency, but deciding the right action is treatment with steroids today. EMS is also fun because we don't get labs, we don't get imaging, and time. Sometimes time is the easiest way or the most effective medication that we have in emergency medicine. Just watching somebody for a little while, seeing how they progress. Both in EMS and in adrenal insufficiency, especially in a patient in crisis, we don't have that luxury of time. So it can be a challenge to make a rapid decision of a condition we don't see very much in a way that we don't do very often. That can be a little bit difficult. And we talked before, protocol-driven care. There is some variability in protocols, whether treatment for adrenal insufficiency is present in the protocol or not. It's in my protocol set, but because my clinicians don't treat it too often, it's not going to be a protocol that they have memorized. Like our cardiac arrest protocol, they've got that memorized. Our asthma protocol, they have that memorized. Those are ones we use almost every single day. However, adrenal insufficiency, even if it's in the protocol, even if it's been trained to, it's just not going to be as familiar. Just like the part of town you only drive to once in a while, you got to look it up and you have to get that reference, even if you have the map available. And then another challenge, state law may require, allow for, or prohibit use of patient medications. These are increasing in number throughout the US, but not all states allow for patient supplied medications or or an order from the patient's own physician to give medications that is supplied by the patient. or to follow a plan of care for the patient. My state of Missouri, there is a state law that allows for patient medication to be administered and a plan of care to be followed, and that's also specifically mirrored in my protocols, because I think that's a great thing. Your doctor orders something, let's do that. So how can I prepare for an EMS encounter? What things can you do to be ready if you call 911 and if EMS arrives? One is just identification. So if you're alone or incapacitated, making sure you have some sort of alert and identification. So necklace, bracelet, card, or something else that clearly shows adrenal insufficiency. Again, we respond to lots of emergencies every day. Lots of people present with just being tired, weak, altered. That's a really common presentation, especially when we talk about some of the other crises going on in the US right now. So the more you can trigger EMS into knowing this is why I'm altered and this is what needs done with a medical alert bracelet, the easier it's going to be. I'm a big fan of like an information sheet, specifically for adrenal crisis. So the more just-in-time education we can provide for our clinicians, the better they're going to understand, comprehend, and provide care. A medication list is always helpful to have. I'm not convinced that every paramedic in the country would look at a medication list, identify steroids on it, and then think, oh, this might be adrenal crisis. I'm not even convinced every hospital emergency department would be able to do it, because again, that's just not something that we see terribly commonly. So it takes a little more thought, a little more processing to understand. And I think something you can do to prepare ahead of time is a physician order for care. In those states that allow for it, having just written communication, very simple, from your physician describing, what is adrenal insufficiency? It's been diagnosed, it's a risk in you or your family member, and what to do about it can be really, really helpful just to tell the paramedic, oh, I have a written order from a physician. This is legal. I can follow it as long as it's within their scope of practice and the states allow it. And then medical preparation, how can you prepare? If you have an injection kit or a home dose of hydrocortisone, getting that ready. Again, most paramedics are going to be able to see it, say, yep, I can give this medication. It's a better medication, but it's not commonly carried by EMS just due to amount that we would use it and cost constraints, and it's just not that common. So it hasn't gained popularity yet. So if you can prepare and have a home medication dose ready and available, that is going to serve you better, be more readily available, and be quicker to administer. One thing I think is really awesome to do is coordinate ahead of time. So I love preparing for incidents and events. One of my favorite lines in meetings is like, all right, do we have any impending disasters coming up? My staff don't like it, but I think it's good to always prepare ahead of time. In Missouri, it started in St. Louis and it spread, and we have it now at the University of Missouri, is what's called the STARS program, Special Needs Tracking and Awareness Response System. So what this does, it's a system, patients get enrolled, their information goes into an online database. Everybody has the right security compliances for it, but it goes into an online database. That information is then shared with the ambulance service ahead of time. So the ambulance service can look and say, oh, I know I have a patient with this condition. Here's their normal, here's their emergency treatment, and it gives those physician orders for treatment ahead of time. It's really great if the patient and EMS can meet ahead of time. So we have some folks who do outreach. They'll go out, talk with the patient, make sure everybody is on the same page. What's going to happen when we call 911? Who's going to show up? What do we need to do when we get on scene, so that everybody's aware and familiar ahead of time. If you feel like you don't know what's going to happen when you call 911, reach out to your local ambulance service, see if you can make a visit there, if they can come out and make a visit to your house, or just have a phone call to coordinate ahead of time. That will go a long ways to reducing your stress, anxiety, improving the care that EMS is able to provide, and have a more coordinated response going forward. All right, a couple of things that you may need to say to EMS to kind of trigger them, because they may be task focused. Again, there's a lot going on, it's chaos, and it's their first time encountering you. So just the words that could be helpful. I have adrenal insufficiency. This is an adrenal crisis. Or here's my medication. Can you please give it? My doctor said it's okay. Something like that may just trigger them to think, oh, this may be different than what I'm expected to see or used to seeing. Oh, adrenal insufficiency. Let me look for that in my protocol. Here it is. So that can be a really helpful thing. I love it when my clinicians look stuff up in protocol. I really try to encourage that. I look stuff up in my own protocol. I wrote them. I know them very well. I still look stuff up because it's good to reference and get that response. Okay, so some takeaways. Not all EMS units are the same. There is BLS, ALS. Good to know what's available in your area. EMS may or may not have hydrocortisone. It's probably going to be less likely that they actually carry hydrocortisone. Be prepared. An injection kit, an ID, a care card can be really, really helpful when EMS arrives. Use clear and concise words. Adrenal crisis, give them something to look up and look for. And then if there's conflict, if you're not sure what's going on, ask to have the clinician speak to medical control, especially if there's a delay in getting the hydrocortisone. Can't promise that medical control will always give the right advice, depends on who it is and what their knowledge is. However, getting a physician on the line, that next step in a coordinated way can go a long ways to improving care. So thank you for your time. EMS is fantastic. I love my EMS clinicians. I am very passionate about giving good pre-hospital care. And I think you all would be on board with that as well, wanting good clinical care in the pre-hospital environment for you and your loved one. So appreciate your time. Let me know if you guys have any questions. Have a good day.
On behalf of NADF, I want to thank Dr. Stilley for a wonderful presentation. We do have some really good questions to send off to him, which we will do and get you the answers as part of our follow-up to this conference. With that, I'm going to hop over to our next session, and I hope you'll join me there.